Big welcome to all our attendees and a special thanks for our excellent panel here who are going to help us in discussion, antibody testing and the economic impact and organizational impact, India's learnings and best practices from other countries. Today, when we woke up and we read the news, we all saw the sobering statistics that were published about COVID in India. We crossed the 1 billion mark of recorded cases, and sadly, we have crossed 25,000 deaths. Now, this is not decreasing, and we are still in the upward trend of the slope, and this is having a profound impact on healthcare and, of course, on the economy at large. India is one of the most affected countries of the pandemic. And to slow down this virus, the government has implemented a series of lockdowns across the country. And now, of course, different states and districts are also doing this in their own way. This will perhaps slow down the spread a little bit, and this will perhaps enable our healthcare systems to be a lot more ready and better prepared as the cases increase. But in the meantime, our economy is taking a hit. Goldman Sachs has suggested that it's probably a 45% economic decline in the last quarter. And the government has initiated some packages, $266 billion support package, which represents 10% of our GDP. But some argue that it might be meager, or it might be too little too late, or it has to be taken in better context with how to both handle the disease as well as the so-called unlockdown. Industrial production in the meantime has dropped, and data from the Reserve Bank show that consumer confidence is also collapsing. The one phrase or term that you see very frequently is uncertainty, and that is something that hopefully testing will be able to shed some light on to understand how individuals and populations are responding to the virus. The lockdown has also put tremendous pressure on the healthcare industry, be that in delivery of service, availability of PPPs. I saw an amazing article by Dr. Devi Shetty of Narayana talking about the availability of clinicians, not just hospital beds. And at the same time, the providers are also dealing with lower footfalls, reduced elective surgeries. Anywhere from 40 to 60% of other procedures unrelated to COVID have dropped. Where are these patients going? What is happening to their confidence in the healthcare industry? And what are we doing about this uncertainty? If you consider the timeline, we are probably in roughly 4 months of lockdown, or since the first lockdown was initiated. What has happened since then? What are we doing with testing? I think now the word PCR is a household term. Every household knows what a PCR test is. And this is something that was unimaginable just 5-6 months ago. Being in the medical field, in the diagnostic field, of course, it's normal to us, but we have been put in the forefront to think about the response. Test, treat, and track, a term coined by the WHO and also used by ICMR, still remains a very, very important tool in our fight against COVID. So what is happening with that? Over the last 4 months, from PCR, we've had antibody tests, rapid antibody tests, antigen tests, combination tests. So many tests have been coming forward. And there is a temptation and a tendency to use the term immunity passport. What does that really mean? And are we truly safe? What sort of data are emerging? What are other countries doing? I think we need to be very cautious as we address these questions, because there is no one test or one series of tests which is going to clear everybody and say, okay, we are good to go. But if we take a nuanced approach, if we take a medical approach and an epidemiological approach to understand the disease, understand the patterns, and then take decisions on a population or an individual, then we have the information that will help us recover from this, both economically and health-wise. The antibody test has been much touted. We've had Indian companies, multinational companies, ELISA technology. We have the spot test. We have the CLIA-based test that Roche provides, and many other companies are providing. What do we do with this information? And here again, I want to make the distinction that there is an epidemiological element when we are testing a large population or understanding a hotspot, and there is an implication for an individual. What do you do with the result for one individual, or what do you do with the results for a factory, or at an airport, or at a hotel? So we have a fabulous lineup of speakers who can help us understand both the clinical side of it, the infectious disease, how that works, what are the population based studies that we can get out of we have I'll be starting off with Dr. V. Ramasubramanian, who is a senior consultant in infectious diseases, HIV, and tropical medicine at Apollo Hospital, who will give us the technical, clinical insights as far as patients go. Dr. Nandini Sethuraman, MD and Associate Consultant, Department of Microbiology at Apollo Hospitals, who will talk to us more about the lab test and explain that in some detail. Jyoti Mayal, wonderful of you to join us. She's the president of the Travel Agents Association of India, one of the industries that links all of us, various industries, healthcare, non-healthcare. And of course, we're seeing the turbulence that you're facing, Jyoti, and we'd love to hear your perspectives also. My friend Chandra from Thyrocare, we've had a long relationship, and really Chandra is someone who understands the nuances of testing at scale, and also how it relates to various corporate clients that Chandrasekar and Thyrocare are addressing. And finally, we'll be bringing in my colleague, Dr. Peter Ramge from Roche Diagnostics Global. He is kind enough to join us from Switzerland. It's early in the morning and he's having his coffee, but he's joining us. We already have 150 plus attendees, and we'll probably have some more. To all my wonderful panelists, I'll open it up to you in the order that I introduced you, to share your views, maybe spend 4 or 5 minutes each to talk about your perspectives. I know some of you have some slides. Go ahead and share those. And after that, we'll come to some pointed questions that tie healthcare a little bit with economics, perhaps. And then we will, of course, open this up to audience questions. So starting with Ram, over to you.
Thank you very much, Shravan. I'm happy to be here with you this afternoon. And I shall be giving you a sort of a clinician's perspective on managing the current wave of pandemic infections and how probably our approach should be. So the idea is to talk to you about the preventive aspects of COVID at this moment. It is very clear that we need to have a change of thinking with regard to our approach to treating patients. As an infectious diseases specialist, I can very well understand that the future of medicine is going to be, one, preventive, and two, personalized. We have gone beyond treating everybody the same way, and I'll tell you the reasons for that. If you look at preventive healthcare in infectious diseases, it is a question of both prevention and customization. We are faced with the enemy, the antimicrobial resistance issue, and we have very clearly realized that we have an escalating resistance on one side and very few new antibiotics in the pipeline to deal with these infections. So we have now gone on to, it is no longer infection control, we are looking at infection prevention. We are no longer calling it as treatment of infections, we are looking at antimicrobial stewardship. And antimicrobial stewardship basically is a program to ensure that people use antibiotics wisely. And the most important aspect of this is diagnosis. In fact, there's a new aphorism which we say that diagnosis is not everything, it is the only thing. And without diagnosis, we are not going to be able to manage our patients better. This is specifically to do with infectious diseases. If you look at therapy, we are again learning that each individual is different. What we apply for a population of the United States or for Europe may not be applicable in India. The pharmacokinetic, the pharmacodynamic patterns of drugs and antibiotics differ. So we need to understand the local population and learn to use our drugs wisely. Simple, mild changes which we apply in the way we administer drugs or time the drugs is enough to make big changes in the way it causes effects. We have again realized with oncology also that prevention, for example, Angelina Jolie's intervention of bilateral mastectomies, just because she had a gene which predisposed her to a cancer, is also being used in other aspects of medicine and infectious diseases. Adult immunization is picking up in a big way. Even though we have vaccinations are present only for flu and probably for pneumonia in the elderly apart from shingles, we have realized that by using these vaccines and preventing a person getting hospitalized due to flu can impact on the development of infections in hospital or hospital-acquired infections and also the occurrence of resistance. So the use of antibiotics can be minimized by giving a person pneumococcal and flu vaccine where it is indicated. And lastly, with regard to public health, we are still lagging. So far, epidemics have been of interest only to historians, and epidemics are characterized by the dramatic desire to assign responsibility. In other words, we are looking for scapegoats to put down whenever there is an epidemic. Should we blame the government? Should we blame the industry? And that goes on. But I think it is time to change our approach. If you look at the challenges in India, we are faced with, of course, lack of awareness and probably poor education amongst the masses. We have societal inequalities, the typical word of all are equal, but some are more equal than others. So we have that in all facets of our occupations. We have, unfortunately, a lack of individual and civic responsibility. This is probably associated with education, but there is definitely a lack of civic responsibility. The social support structure in India is not something which I would be proud about. We also have a working population which is significantly varied. We don't have blue collars or white collars. We have various shades of colors in our working population. Most importantly, we have cognitive biases. This is not specific to India, but the present bias or the immediate victim error. Basically, we are looking only at what is happening now. For an example, we are looking at getting more ventilators to solve the problem and save patients, rather than pushing more money into prevention by using of masks and physical distancing and infrastructural changes. And lastly, issues of testing. We know the expense involved with RT-PCR. We know the less expense involved with antibody. We also know the ramping up of tests necessary to cater to a population of 1.3 billion. All that has to be kept in mind when we come up with interventions. If you look at the antibody testing, as of now, it is a very useful intervention in handling this pandemic, but it is not a panacea for all the testing which is required. I would suggest that the testing be limited to certain situations. It is definitely not for acute infections, because we realize that it takes 7 to 14 days, and the longer it takes, the more sensitive it is. So I think it is definitely useful beyond 14 days, where you already lose the window of quarantining the patient or isolating the patient. It is useful probably in studies of convalescent plasma, where we know that the person has antibodies and can donate. Healthcare workers and other frontline workers, I think the antibody testing will be useful. Useful in migrants who probably will be returning back to these states from which they have migrated and gone back home. Especially useful in travel, and practically return of work, more to do with a psychological benefit, and definitely also safety of the person at work and the other co-workers. So we need to come up with algorithms. This is one algorithm which actually we have discussed with Roche and looked at. This is appears a little complicated. This will need a lot of modifications, but we are looking at ways in which we can customize the use of antibiotics in different segments of the society to get maximum benefit. I think if we are looking at personalized preventive healthcare, this picture is the epitome of this definition, where it is personalized. You look at the little fellow, he's protected. What is priority for him at this point is a mask and not something to cover his nakedness. And this is how our approach to preventive and personalized healthcare delivery should be. So I'm going to stop here, and then we will take up the questions later. Thank you.
Thank you, Dr. Ram. I think I'll take it over from here. So hi, everyone. This is Dr. Nandini Sethuraman. I'm a consultant with the Department of Microbiology in Apollo, Chennai. So today I'll just introduce you to some basic concepts of serology as far as the SARS coronavirus 2 is concerned, and just take you through a few questions that commonly crop up in people's minds when we talk about antibody testing. If you look at the immune response to SARS coronavirus 2, the virus that causes COVID-19, the immune response is mediated both by the innate immune responses as well as the adaptive responses. The adaptive responses has two arms again, that is the cell-mediated immunity and humoral immunity. So at the outset itself, I just want to put it out there that antibodies are definitely a part of the overall immune response to the infection. So following an exposure to the virus, the people who end up developing infection have a wide spectrum of infections. So they may remain completely asymptomatic to mild to moderate to very severe infections. And as you can see in this picture, that the asymptomatic individuals are probably the most the fighters, the real fighters for the infection, whereas those as a result in death, the immunity has basically failed them, and there are a lot of immune dysregulation happening there, and cytokine storms stepping in, which actually contribute to the pathogenesis of the disease. Following exposure to the virus, roughly a week to two later, the patient develops symptoms. This is typically what happens, what we call as the incubation period. So if you look at this point of onset of symptoms, almost a week before maybe 3 to 4 days before itself, your viral markers start replicating. This is unique to COVID-19. Many of the other coronaviruses have the highest replication happening a few days after the patient shows symptoms. But here the PCR positivity or the rate of pickup for a PCR will be maximum a couple of days here and there from the onset of symptoms. What happens after a few weeks, approximately a week to two later, is that the antibodies start rising. Here is another unique feature for COVID-19, that both the kinds of two major kinds of antibodies that we study usually, the IgM and IgG, kind of arise together. So the distinction between the two is kind of lost with COVID-19. However, IgG is the one which lasts longer. How long is a question for another day. So there are certain unique features with the serology for COVID-19. As you saw in the picture, the IgM and IgG kind of appear together. So any antibody testing cannot distinguish recent or past infection. Even if you're looking only at IgG, it's going to tell you that there has been an exposure, but it's not going to say it's a past infection. And there are issues that the antibodies may cross-react with other coronaviruses. So there are a lot of other coronaviruses, at least 4 other common coronaviruses that cause common infections, and then you have the SARS coronavirus and the MERS coronavirus, which have more or less been taken off the limelight now. However, with more sophisticated tests available, we are looking at tests which are coming up, which have very few cross reactions, and tests should basically look at completely nullifying these cross reactions with other coronaviruses. What we're also seeing is that more severe infections tend to have higher antibody titers. So like I said again, the arms of immune response are 3 different arms. So it's not just the antibodies which are protective. And the antibodies that you actually measure, are they protective? This is a very common query that everybody has. So you have a term known as neutralizing antibodies. These are the subset of antibodies that we detect, which actually directly react with the virus and neutralize them. And how long do these neutralizing antibodies last? This is another question that we'll look at answering in a couple of slides. So, if you're thinking how many individuals are in who have had an exposure to the virus, how many of them will actually seroconvert? So how many of them will have antibodies? So there are a lot of studies which are showing that almost all people do seroconvert after they have had infection with SARS coronavirus 2. But only thing is the time of measuring. There are some studies which will tell you that 10% did not seroconvert, but their follow-up period was only till 15 to 20 days. But at the end of 4 weeks, if you're looking at most of the studies, they show that there is complete seroconversion. But how long do they last is a question that has not been very well answered so far. So if you look at the example of the other coronaviruses, at least the 4 other common coronaviruses, there have been cases where patients have had a reinfection because the antibodies return to baseline after a year. But we don't know if this is because of the decline in immunity or the virus has changed itself, which these viruses so often tend to do. With the example of SARS coronavirus, of course, it has been patients have been followed up for 6 years, and even at the end of 6 years, they had detectable antibodies to SARS, which is probably the reason why SARS never re-emerged. And MERS coronaviruses have been seen, the antibodies have been seen to remain as long as 3 years post-exposure. So we don't have such robust data, yes, of course, because the epidemic has only been going on for about 6 months. So we don't know for how long these antibodies will actually last. So where are the use cases for serology? In a large scale, you can use antibody testing to screen populations of infected individuals to see if they have developed an immune response. And in cases where a PCR test is not available, we do know that there are certain designated centers in our country where PCR testing is available. So there may be areas where you don't have PCR testing available, and so there the patients with symptoms did not seek a PCR test, or if PCR test initially was negative. So there is a study from China which actually showed that the median time to presentation for any individual to the hospital is 5 days. So and it can range from anywhere between 3 to 21 days. So when the patients present very late to the system, it can aid in the diagnosis. This is a secondary utility for serology. And of course, seroprevalence studies, serology is the go-to. So like I said, mild infections, asymptomatic infections, patients do not come forward for testing at all. So serology is the only method by which you can pick up these populations. Certain other potential applications for immunoassays is to aid in the estimation of disease stage. This is something that we're still working on. If we have some kind of system whereby you can use serology to distinguish early, acute, early, and convalescent stages, this is still being studied. And can you assess the immune status of healthcare workers? Like Dr. Ram also alluded to this. Presence of antibodies itself will probably not tell us that it's going to protect from infection, but antibodies are definitely a surrogate marker that the patient has been exposed and probably has recovered if he is no longer symptomatic. Also, there assessment of convalescent plasma donors, where you can use antibody testing, and also to guide identification of low risk individuals to exit quarantine. So previously we had a system where the Indian government recommended that there should be 2 negative PCRs for patients to exit from quarantine. This is no longer there now, and probably serology can step in at that point to sort of tell you that the patient has developed antibodies and can probably exit quarantine. So these are potential applications which can probably be explored. So with these few introduction points, I'd like to hand over the discussion to Jyoti.
Thank you, Dr. Nandini. Thank you, ET and Roche, for getting me over here. And between these glitterati of medical people, I think, I feel that I think tourism must be very, very important, and it is, certainly is. And we've seen that it actually 10% of our GDP is based on tourism. So I think we really need to get out of it and see how we can proceed. And I'm sure we'll be able to achieve all with all your support and all the work that Roche and other people are doing in this medical field. And we actually salute them, and we honor the people who've been working from the front and working very hard. And we actually, all our strength, our sympathies who've lost lives really go towards them from the travel side. And I, sitting on the travel board, would like to say that first before I move on. Yes, it's been a very great, and everyone knows it's been a real catastrophe, something which we had never seen. The current times of COVID-19 is something the travel, tourism, hospitality industry could have never envisaged. I think the world outbreak of COVID-19 has brought the world to a standstill. And I'm going to say this from my perspective, because tourism is, like I said, the worst affected of all major economic sectors. So, and whenever a calamity like this happens, I think the travel, tourism, hospitality, aviation industry is the first to be hit, and it's always the last to revive. The COVID-19 pandemic has had a significant impact on our tourism industry due to the resulting of travel restrictions, as well as the slump in demand among travelers. The tourism industry has been affected in such a way that we really don't know when it is going to revive. Even when the medicine does come in, the cure does come in, we are not very sure when the sentiments or when the confidence of a traveler is going to go up. According to the UNWTO, which says that the international tourist arrivals might have decreased literally by 30% till now in 2020. And that's leading to a potential loss of at least $45 billion. And in many worlds and cities, the planned travel went down by 80 to 90%, and literally 150 countries have closed the borders because of this. So the globally tourism sector accounts for literally, like I said earlier, 10% of the GDP, and even 12% is what our employment structure is. So the whole thing has come into a chaos. We really don't know where it's going. We know the losses are into trillions, and we know that the export money that's going to be coming in as foreign exchange earnings are going to go. And it's unimaginable how this is going to be the damage is going to be controlled, and how the travel and tourism industry is going to revive. Saying this, yes, I know, that is the global perspective, but the Indian perspective also, we have seen a great unemployment happen, and a lot of people are trying to open offices, but we don't know how it's going to happen, because like I said earlier, the confidence is not there. We are not still sure when we would like our staff to come in. The corporates are struggling, we are struggling, the travel industry is struggling, the hotels are struggling, and we are expecting literally like 3.8 crores of direct and indirect unemployment because of that reason, because we don't know when the business is going to start. And what is tourism really about? I mean, I think the futurism of tourism is sustainability and authenticity. It will be the key principles actually coupled with a multi-purpose, how it's offered, where visitors and tourists can experience the tourism of tomorrow. And that is by integrating innovation and developing cutting edge principles for the future, how sustainability, how medicine, how healthcare is going to come into effect. So most importantly, saying that's the perspective of travel tourism and where it's gone. But speaking about medical, where it is, I think most important is the scare that there's no vaccine, there is no cure, there's no medical attention. We are not confident how the medical is going to be supporting us. So we know, after staying literally for 120 days within under a complete lockdown, that what social distancing, what hygiene, what sanitization, and how, that's going to be the new normal of tomorrow. And that is what we feel, that the new normal is going to be the one which is going to evolve, and that's how new tourism and the normal tourism is going to start effect. Saying that, again, I'm going to come back to the medical thing, because I think it's a global epidemic. It's a global pandemic, and the pandemic is global, and it's not limited to a certain region or a country that we can get away with it. So I would say there are 3 S's which I believe in. The 3 S which I believe that we need to follow is the safe, secure, and sustainability. These are the 3 S's we need to follow and see that tourism actually moves forward with that. And yes, it's time that we increase, and India has agreed to increase the testing, and the importance of antibody testing has come into focus. Like I heard Dr. Ramasubramanian say that, and even Shivam say that, that we understand that, even a lay person is now being able to understand these words, the antibody testing, what it is and what it's going to be like. So I think I understand that, but I understand that India has been struggling a lot, which I'm sure you will be the right person to even tell us, that we are under the diagnostic centers are not enough to carry mass tests all everywhere, and that would be required. And I think that's going to be very, very important to increase and boost the ecotourism and the ecosystems. Yes, tests can play a very critical role in the COVID-19 by helping healthcare professionals to identify individuals who have overcome an infection in past and have developed immunity. We also know that the rapid tests are going to be, and we would like that the rapid test comes at home, which we could actually be using it by pricking a finger and then getting results in minutes, and that's how we should be when it's coming to travel and preventing. But I think the concerns persisting about potential is how good, how false, and that needs to be told more to the traveler, more to the travel community, to actually impart that knowledge to our customer who's going to be traveling, or our staff, that how good these tests are going to be, and what are the positive points of this test. And I think that's very, very important. Another thing which I feel is very important is that the knowledge that's being filtered down is, there are too many, it's too much. So we really don't know what to accept and what not to accept, because the whole time on the television, on media, we are reading about tests, we are reading about antibody tests, we are reading about other tests. So we really don't know how and what to really go about it, though we keep seeing on the TV that we are having question answers to specific questions, but I think the clarity is still not that way. But seeing that we don't know when the vaccine is going to come out, when the cure is going to come out, when the medical, but I think the main thing to actually put a person to motivate to open his offices in a corporate world, or our offices, or the hotels, or to start traveling, is something that we need to at least know that the person I'm sitting next to, the person I'm going to be working next to, is safe. And I think those regular tests and those antibody tests which is something which is going to help. And that's what I believe has been filtered and whatever readings I've done, that those are going to be playing a very important role. We've seen that happen, and we've seen the things change in the perspective. Countries like UAE have come into the possession already that they, unless there's a health passport, they will not be allowing you to come back. And I've heard that they've opened to 40 countries. They'll from UAE to other countries, 40 countries have already opened, and they are actually insisting on that, without which they will not be traveling. So I think it would be very easy if we have a health passport. The QR code is uploaded in the bookings, and we have the scan of the history of the passenger who's going to be traveling, and we feel safe traveling. And if that sentiments are aroused in a traveler or in the world of wherever we are staying, and we know that people we are surrounded with do have antibodies or they are safe, I think it would still motivate a traveler and would move forward. So saying that, I'm going to say that tests can play a very crucial role, and I'm sure that by helping the healthcare professionals to identify individuals who have the infection, who can have the infection or cannot have the infection, is going to play a very, very major role. I've seen a lot of countries have started getting into rapid testing and mass testing, which is not happening in India. But again, I feel that India is a country where we are facing challenges of not enough diagnostic centers. That's what I've been told by Ministry of Tourism, who I work very closely with. But seeing the upscale in Maharashtra recently and in other cities, they've started doing that so that, they can, because it is the need of the hour, what we understand, because unless we do that, we really don't know. So it's whenever we come out in the open, whenever there is going to be, it's going to be herd community, and it's going to spread much more and more. So I think looking into all those perspectives, I feel that AB is going to be very, very important. And I think that is how we would need to be moving forward with, like I've always said, man is not an island. And, we are human beings. We are not robots. We need our freedom. We need to experience travel. We need to go and hug each other. We need to feel each other. And, that's what all travel is all about. And that can, and, without that, I think after the lockdown opens, we are just dying to get out. And we've seen many, whenever we have taken these up to from lot of our members and lot of our hoteliers and other people, that everyone is dying to get out, and the surveys are talking about it. So we do need something to motivate us, to make us feel that we are safe in this environment till the time there's no vaccine, there's not a cure. And I think precaution is better than cure. So we always say that, we've always heard that while we are growing up. So I think to relive the tourism part of it, and to again experience the freedom and the experience of life, and to enjoy life, we would need sustainability, and that would come from these medical things. And thank you so much, and I leave that open for my next questions.
Thank you, Jyoti. Over to you, Chandra.
Yeah, thanks to Jyoti and other panelists. I belongs to one of the largest laboratory segment. Of course, it's a testing time for all of us. It took 110 days for the COVID-19 cases in the country to reach 1 lakh patients. Just 56 days more to go 9 lakhs. So when it comes to COVID-19 test, we don't have a month or weeks or even days. We have to act on an hourly basis. The biggest challenge for lab like us to hope of testing and scale proportionally with the disease spread rate during this lockdown time. We started with PCR assays exactly 110 days before, with a capacity of to process around 100 tests per day. Today we have capacity to process around 5,000 tests per day, which we are doubling in another 30 days. We are largely immunoassay guys, have experience in handling large volume of thyroid, vitamin D, and other infectious tests. So we were looking some kind of immunoassays to complement and support COVID-19 situation from the day one. When we heard about antibody assay from Roche, we are quite excited. Since we may not create any new infrastructure, overnight we have realized we can process around 2 lakh tests per day. So we are ahead of the industry and ahead of the COVID-19 scenarios in India. So then it comes to regulatory guidelines, which was very dynamic. We have to track on a daily basis and adapt without delays. After a lot of waiting, ICMR has allowed private labs to perform antibody testing by end of June. We moved very fast and activated assays for the general public and corporate government segments. Today, anyone can avail this test, just giving 3 ml blood anywhere in India at just 1/5 of PCR cost. As there are a good percentage of asymptomatic cases, understanding post-exposure is equally important. ICMR has like proposed 17 categories of like possible groups, which covers all segments in the society. So we could see like a lot of inquiries from the time we activated the industries like manufacturing segment or IT sector, all kind of service industry, including food retailer chains, airline, film industry, government offices. So it took 100 days to do 100,000 PCR tests for a lab like us, but we could do 50,000 antibody tests in just 15 days. So that's the scale possible with automated immunoassay solutions. So as per my estimate, there are around 10,000 immunoanalyzers, at least in the country, installed base. Assuming average throughput of like 100 tests per hour, we could do around 1.2 crore tests per day. So we could screen entire population in just 100 days. So we have been publishing our findings on a regular basis. It's available in public domains. So we could notice exposure level like anywhere between 2 to 30% in major metro cities. So overall positive rate appears to be 13%. But if you ask me what is the testing ratio, so we have done 80% of the cases from corporates, industries, so about 15% healthcare workers, and 5% from general public. But this is too early to conclude anything. But we have been sharing the data on a regular basis as and when we report the cases. So far, we have reported around some 60,000 antibody tests, probably the largest in the country. Yeah, this has been like exciting journey with antibody testing. To sum up from my end, so antibody test is now available for corporates and general public. ICMR has released a comprehensive testing advisory on 23rd, I believe, on June. We enable all government and private sectors to perform antibody testing in the large scale. I think that will be very useful, like for all industries to go through that once. So labs can use existing infrastructure and scale antibody testing almost 100 times faster than PCR. So I believe now all labs, private labs, are allowed to do antibody testing. So lab-based assays are like much cheaper than rapid antibody test. So this is what like I want to convey. I leave it to Dr. Shravan to take this forward.
Thank you so much, Chandra. Peter, over to you.
Yes, so thanks a lot for giving me the opportunity to present today to you. I'd like to give you a bit of a, I've been asked also by the organizers to give you a bit of a background on the what's happening in the rest of the world when it comes to SARS-CoV-2 testing. So I'm just starting very basic. I understand we have a very much mixed group of people listening in, and I think I also just want to reiterate the points that have been mentioned by my previous speakers. So basically, this is what it's all about, right? The virus enters the body, it reproduces, immune response is triggered, and basically based on that, we see a certain, we want to basically measure, and then eventually this reaction is then eliminated, or that helps eliminate the virus, and the individual recovers. So what are we trying to find out? This is again very, very basic, and it has been said, so basically we want to know whether a person is currently infected, or if that person has been previously infected with SARS-CoV-2. This is basically the two major questions we want to answer with testing. And again, this is a much simplified slide, but just to reiterate the message here that SARS-CoV-2, that virus that causes the COVID-19 disease, is basically showing a very specific pattern of development of antibodies. So while you typically would see a different time lag, for example, first showing up IgM antibodies and then IgG antibodies, you see that with most other pathogens. In SARS-CoV-2, actually it is happening at parallel, and also as Dr. Nandini had said previously. So it's actually quite a special situation that also then requires also special needs when we look at testing for an immune response of the SARS-CoV-2 assay. So this is a slide that basically shows you testing policies that are currently implemented in the world. And this is basically just, you have to remember, this is just PCR testing. There's actually no overview. I couldn't find a slide that shows serology testing policies. But this is, if you look at it, quite a helpful slide that basically says where can people get tested, and the blue basically is public testing, and that includes also patients or people that don't show any symptoms. I think that was also mentioned by the previous speaker, especially Dr. Jyoti, who said that it's like you really want to find out, is that patient or is that person who sits next to you, that works with you, who travels with you, is that being at risk, is it being infectious, for example, and this is also basically different policies that are in place. So right now, India, for example, is mapped that anyone with symptoms can get a PCR test. Whilst, for example, in the US, in North America, and also in Germany, for example, in Portugal, anybody, or in Russia, anybody could get a test, or in China as well, PCR test, not diabetes. That's very important. Another thing is now, of course, now this was PCR testing, so basically the testing for the acute infectious diseases, but also what do countries say, what kind of other strategies are out there outside of India to basically look at serology testing and what actually is the purpose. And I think it's just to reiterate what has been mentioned by the previous speakers, it is really about testing and understanding the rate of infection that has happened in the population. So the major use case, as we say in diagnostics, is really about making sure that we understand how many people were actually infected. And then the secondary ones would be the ones that we already discussed, the fact that whether people have certain immunity, possibly, whether they have been exposed, whether maybe in special cases have shown symptoms, and then maybe the viral shedding has stopped, so you can't find the virus anymore, but you still already would see an antibody response, so you can put a proper COVID-19 diagnosis. So this is an example from the US, and the CDC, of course, is one of the world-leading authorities. We've been seeing these strategies as well in Switzerland, for example, where I live, or in other parts of Europe, such as Germany, the UK, Sweden, for example. So a lot of the countries in Europe and the US, again, they have these kind of surveillance strategies now in place, because it is very important, as mentioned by the previous speakers, to understand the true extent of the infectious event that has happened in our societies. Again, when it comes to prioritization, because obviously when you have limitations of testing, and that is not only the case for countries like that do not have enough resources, but for example also here, even in Switzerland, I mean, it's not that I can just walk anywhere in and can get a serology assay. It's really a little bit of a hassle, let's put it that way, to get myself tested. So, so it's about priority, it's about high-risk groups, it's about making sure that you have people who work in the healthcare industry, that food supply workers, that they can get tested and basically may have already developed a certain level of immunity. So serology testing is also very, very important to help society to return faster to normality. And I just want to very briefly touch base on the antibody test that Roche has developed, the Analexis anti-SARS-CoV-2 test that can run on large machines on thousands of assays per day. So actually we look at a combination of antibodies, especially focusing on IgG, and we detect high affinity mature antibodies, because those are the ones that actually indicate an immune response. It's, as said previously by the previous speakers, it's very important to note that we don't know the exact extent of the immunity that's currently under debate. Nevertheless, we have encouraging results that at least for a certain amount of time that people to develop neutralizing antibodies, so those antibodies that basically will then block the virus from entering the cells, and also would mean that the patient can recover. And that would also speak to the clinical course of the disease, obviously, because people do recover. And so this is the main point. So again, we have this test has been designed specifically for epidemiological research to really understand the true extent. Especially, and that's something maybe to point out here, a lot of people who undergo SARS-CoV-2 infection, they may not develop any symptoms, or maybe have a minor headache or something, but that's maybe something that you have anyway. And there are studies that speak of up to 80%, and especially younger people we know now are at a lesser risk of developing any symptoms or even develop severe symptoms. So really understanding the true extent, and then also that leading into a certain knowledge about the true infectious extent in a society, and then leading to this discussion of this herd immunity that we know that actually is helpful to stop further spread of a virus. That's why it's very important to do these tests also on a mass and larger scale. I think I'm not going to go through these because this is something that we have already discussed previously. Just to maybe summarize very briefly, I know we're running a little bit late here, so there's quite a few testing recommendations out there. Again, the CDC has published, also the European Center for Disease Control and the WHO, just to point out the major ones. And again, in a nutshell, it is really the PCR, nucleic acid amplification test. That's another word for it. Is really recommended for diagnosis. And then basically the serology is important for serosurveillance. And then again, these other cases that have been discussed. Roche has been working with a lot of health authorities globally. We have our tests implemented in quite a few, or been asked to implement in quite a few epidemiological studies. From a global perspective, we support epidemiological studies in Spain, for example, also in Sweden, Germany. There's a couple of projects, so it's really nice to see, and I think also in the US, and we also have also some studies going on in the UK, where these things are, where our assays are used. I think in Singapore, also the government is using our Roche assay for this purpose. So we really feel that we are helping to combat this crisis. We have developed an assay that is extremely specific. This is what you want. This is what you need in a situation like this. We're very proud of that. And I think we can also now see that the real world data that we see getting back is generated, that is confirming also that we are really providing a good support in this fight. And I think this is it from my side. Thank you very much.
Thank you so much, Peter. That was really useful. Now, thank you all panelists. You've given us an overall spectrum of understanding of the antibody test, and we're putting some things into perspective. We're understanding that you know it's not enough to just think of one test and immediately think of what you can do with that. You need to think about the overall system. We need to consider preventive protocols, capacity management for different phases of the disease that a patient might have, and also consider what might be the interventions for a population. From the lab, we know now that it's a far more nuanced approach than just sending a sample and getting a result, positive or negative. We need to understand the pathway of the disease, of various immunoglobulins, and what that means for an individual, and what that tells us about the past history of the patient and what might happen after. Jyoti has given us a good idea of what's happening with the travel industry, and I would argue that the travel industry is a bellwether for the overall economy, because you know, Atmanirbhar and self-reliance notwithstanding, we are a part of a global economy, global supply chain. Global innovations are very much impacting our trade and our economy in the country. So we do need the travel industry to be propped up, and whether it is causation or correlation, the economy and the travel industry go hand in hand. So I think we have some good lessons from the Travel Agents Association of India. And this is reflective of other industries, including manufacturing also, where having prudent testing protocols and treatment protocols will help us open up the economy over time. Also, it is important to understand the use cases. There's been so much uncertainty over the weeks, and helpfully the ICMR has been publishing almost on a weekly basis. As we are learning more, not just from India and from our experience with individuals and with populations and through research centers, we're also getting examples from around the world that is helping us to understand and address the different use cases, whether it's for a population, whether it's for a hotspot, whether it's for a factory, or for an individual. And then how can we scale? As Chandra pointed out, in the beginning, there was just one lab. There was one lab in all of India that was dedicated for COVID. That's the National Institute of Virology. Now we have 1,000+ labs that are performing tens of thousands of PCR tests, and potentially able to scale up antibody testing by an order of magnitude above PCR tests, because of the ease of use, because of the ability to scale up the automation that is available. So very, very helpful. As with any situation where we are trying to provide answers, for every one answer or one presentation that we had, I think we're getting about 10 questions in return. And this is a sign of a very engaged audience. We have 240 plus members of the audience, and I've already got a page full of questions, including my own. So I'm going to do my best to look at the questions that I had for the panelists, as well as what's coming from the viewers. And I apologize if I'm not able to get through to all, but we have only half an hour left, and I've literally got dozens of questions. I'll open with Ram. Ram, you have a good eye for what's happening in the hospital. You're seeing patients, inpatients, outpatients, and I have two questions for you, which you might have been getting a lot, probably from the press too. One is around seroprevalence. What is the benefit in understanding seroprevalence? How does that help a community, and how does that translate to individuals? And the related point to that, also as alluded to by Jyoti in her talk, what information can we get from either population-based or individual-based testing that can help us understand presumed immunity and consider safe return to work, safe opening of factories, etc. Ram, over to you.
Yeah, thanks, Shravan. Regarding the first question which you asked about the importance of seroprevalence, the first thing we have to understand is we are not looking at another couple of months and the end of the pandemic. You know, we have seen what has happened in China. This is a disease which is, the virus is not going to go away. Whether it is going to be prolonged grumbling infection, or whether it is going to be first wave, second wave, third wave, it appears as of now the only way we can get rid of the virus is either by a herd immunity, which will take at least 3 to 5 years, or a vaccine, which also realistically speaking will take at least a year or more. So in that situation, whatever we are planning now with regard to seroprevalence, or with regard to, you know, putting interventions in place to travel or the hospitality sector, it has to be long term. This is not something we are planning for the next 3 months till the pandemic is over and then we go back to being normal. So that's the first thing. We are learning quite a bit about seroprevalence. We need to, again, I'm a very strong believer of customization and personalization. You need to have seroprevalence with regard to geography, with regard to temporal distribution, and with regard to demographics. So this is not something which we say, oh, in India, the seroprevalence is this much. No, because what happens in Chennai, what happens in Tamil Nadu can be entirely different from what happens in Delhi or in Bombay. So we are still too early in the phase of the developments to say what exactly will work or what exactly should be done. But suffice to say that we need to gather more information for us to be able to predict whether it is therapy, whether it is prevention with vaccine, or whether it is public health strategies to minimize containment and mitigation of the pandemic spread. All of this, I feel, will a significant extent depend on the prevalence of the infection. So unless we gather information regarding the prevalence, I think we are not going to be in a position to control this pandemic. The second question you asked about travel and hospitality, again, it is too early for me to comment specifically. We still don't know what is the level of protective, the antibody. We don't know how long it stays. Already Nandini mentioned that it takes at least 4 weeks and most of us develop antibodies. But is that enough? Is it going to be like flu that after 1 year you need to have either a booster or another, a different strain to take care of the mutations happening? It is still too early days. We have a long way to go.
Thank you so much, Ram. I've also got a series of technical questions about rapid tests, and so perhaps Nandini, if I can turn to you, and Ram, I know you also have some experience there. Feel free to jump in. There are a lot of questions that are coming up about rapid tests, rapid antibody tests, rapid antigen tests. So how do we put that into perspective? What would be an ideal protocol? And maybe it might be useful again to share the algorithm that Ram has developed to really come to terms with what is the right test. We have so many tests that are available in the market now. But the question is specific to rapid tests, rapid antibody tests, rapid antigen tests. What is reliable? Do we have something reliable now, or should we wait some time? How do they correlate with lab-based tests? Nandini, if you could take that, then we could ask Ram for some further details. And then I have another technical question for Peter.
Yeah, thanks, Shravan. As far as rapid tests are concerned, I'm sure all of us know that there has been an ocean of tests that is currently available, and FIND is an organization that is working on validation of all of these rapid tests. So the problem with I've had some limited experience with several rapid tests, and they all seem to have kind of a variable sort of performance. So there are certain tests which have been validated by the ICMR and put out there. Those are probably the better ones to use. But even so, every lab has to probably do its own validation with rapid tests. Another problem with rapid tests, which I even commented on that JAMA paper, was that the rapid test, we don't know what is the kind of antigen that they use. So they don't really reveal whether it is a crude antigen, the nucleocapsid, or spike. Each of these will have a bearing on the sensitivity and specificity of all of these tests. So I would definitely lean towards using an automated large throughput system which can generate reliable specific results in a relatively short period of time. They're probably not 5 minutes, but definitely you can run a lot of samples, maybe 100, 200, 300 at, in over a period of 3-4 hours, and ensure that it is specific. So another thing which Dr. Ram also alluded to is the prevalence of the disease, which will have a bearing on the specificity of the test. So that's what we call pretest probability. When you have a high pretest probability, you end up with the 100% specificity. But when you do the same test on a population which has not yet been exposed, you would likely to pick up some false positives. So that is where the rapid antibody tests stand. As far as the rapid antigen test is concerned, right now in India we only have one which has been sort of validated by the ICMR. So antigen is basically the viral protein that we are looking at. And issues with antigen testing is that it's not a blood sample, but it's a nasopharyngeal swab again that is required for the PCR, I mean, for the antigen test. So there are some biosafety concerns with that. But performance-wise, the antigen test is said to be very highly specific. We've done a validation of our own also over there and found that it is very specific. Whatever positives that we detected with the antigen are 100% correct. That correlates with the PCR. But there are a couple of low viral load patients that we may miss with the antigen test. So those are the cons. The pros with antigen test is that you don't need a huge molecular lab setup like you do for a PCR to do the antigen test. You can probably just get away with a couple of people who have a proper PPE donned and probably some basic biosafety lab, BSL2 even, where you can run the antigen test itself. So that is a definite advantage that we are seeing with antigen test. But right now there's only one player in the market as far as India is concerned, which has been validated. Probably we need more tests which probably can even pick up those low viral load samples, which will really scale up testing, because you don't need a molecular setup. So even those 1,000 labs, probably every lab will finally be able to do antigen testing.
Ram, do you have anything to add to that before I move?
Oh no, that's fine. I agree with that. Only with time and only with how we upgrade our tests, we will be able to do better.
Thank you so much. The next is a series of questions which I'm putting together for Peter. There've been some questions around our learnings from antibody tests used in other countries. We have a person from the panel is asking us, sorry, from the audience is asking, any learning from widespread use of antibody tests in other countries? Although it's a qualitative test, can we derive a cutoff based on the index value for immunity? That is question one. Another series of questions that I have received, Peter, are around IgG versus IgG-based tests versus combination tests, total immunoglobulin, etc. There are different categories of lab-based tests. Can you share a little bit about that? What is the clinical utility of one versus the other? And on another related note to the above question, what is the cross-reactivity between different types of tests? And do we have any evidence of cross-reactivity with MERS and SARS, MERS 2012 and SARS 2002? These are all questions relating to the antibody test. I'll let you go with these. And then there is one more question that I have on tocilizumab and IL-6. that may be slightly out of syllabus for the purpose of today's discussion. But given that it is an important subject, if you feel comfortable answering that, Peter, what is the utility of interleukin-6 and how does that correlate with the patient's disease flow? You're welcome to take that. Otherwise, we can take that. Over to you, Peter.
All right, thank you very much, Shravan. There was quite a few questions. I hope I remember them correctly. Maybe let me start with the cross-reactivity, and then you can maybe remind me of the next bugs. So the cross-reactivity I can obviously only speak for the Roche assay, and that's the data I'm most familiar with. So when we're developing our assay, of course, making sure that it's not cross-reacting with other existing coronaviruses. And Dr. Nandini also showed in her presentation that there are quite a few of them out there, and every year we have probably several strains that are coming up. It was very important that we make sure that there is no cross-reactivity with those ubiquitous strains, and actually in our test panel, we were able to show that. So you can basically buy those panels and then run them in the lab. And again, at Roche, we feel quite confident that we do not have any cross-reactivity with the other ubiquitous coronavirus strains, which I think is good news. Cross-reactivity to MERS and SARS-1 basically is quite hard to look at because there are no samples anymore, right? So the challenge here is it's basically SARS-CoV-1 or SARS-1 was basically 2002 and MERS was in 2010. So we're talking really about nearly 20 years back, 10 years back. So it's not possible to actually have a look at these samples at this stage. At least I think we've been trying to get some access, and if anybody has some access to samples, please advise, because we'd be loving to get our hands on those. It is probably very likely that there will be cross-reactivity with SARS-1. But again, given the fact that the virus, and Dr. Nandini, I think you also showed in your presentation that this basically was self-limiting, right? And so we assume this is gone, this virus is out of the world. So it is probably not a clinical issue in that sense. I don't know, Dr. Nandini, if you want to comment on that one, because I know it was part of your presentation as well. No? Okay. Then the next bulk, Shravan, was on IgG, IgM, and so forth, right? So this is basically, I think, let me say that, I think the CDC says, for the CDC, this is the US authority, says there is no preference basically if you go for one IgG or if you go for like do a total antibody focusing on IgG. KOL I recently spoke to said called our assay IgG dominant, which I think is a quite nice way of maybe putting it in a clinical context. So I thought I'll share that here with you. That's an important message. What is important, and I think that's what also was stressed by Dr. Ram and Dr. Nandini, is that we have a high specificity. This is what you really want in a serology assay. You want a really high specificity to avoid basically that you find false positives. So this is basically what you really want, and this is what we've been able to show. And again, and I also should say that other companies are also doing good tests. However, I mean, again, I think our assay, we've been showing with our assay consistently a very, very good performance. That's also published now. So I think when it comes to that context, we're quite confident that we, put our horses onto the right, or our money onto the right horse, let's put it that way, use that comparison. It's important also to note that when we developed the assay, he looked, I think, at over hundreds of targets and really tried to identify the most specific one. And in this case, it was the nucleocapsid that we're currently using. And I think there was a third area, Shravan.
Yes, sorry to throw all these questions that you submitted. And I think you've answered a part of it. There was a question about our experiences in other countries and whether there's a learning from that we could apply here. And the last question was around tocilizumab, cytokine storm, and interleukin-6.
Yeah, interleukin-6. Yeah. So with that, I'm not so familiar. I only can say that there's a set of biomarkers, and interleukin-6 is, for example, one of them that are indicative when you have a COVID-19 patient, basically that develops more severe symptoms, needs treatment, that is indicative of developing a more severe form. But I would really like to hand over to Dr. Ram or Dr. Nandini, because I'm sure they are more capable of commenting on this from a clinical perspective. So when it comes to certain levels and so forth.
Ram, would you like to take that, the impact of interleukin-6 testing?
See, we are understanding the pathogenesis of the disease. We know that the virus initiates in pneumonia. So even in asymptomatic people, if you do a CT, a significant number of them will have some changes in the CT scans. But we also know that beyond day 9, all the samples of respiratory secretions taken for culture have been sterile. In other words, beyond the 8th day, the virus does not persist and it dies away. So whatever further progress in the diseases which happens is believed to be the immune response of the body. There is a inflammatory dysregulation leading to an increased pro-inflammatory state in the body. You have a high level of cytokines which stimulate inflammation and cause ongoing damage in the various organs. And this is what is referred to as a cytokine storm, where the high level of pro-inflammatory cytokines initiate damage in several organs. A surrogate marker is interleukin 6. If we document interleukin 6 levels serially and show that they are rising, and especially in a patient who's clinically deteriorating, there is a role for using interleukin 6 antagonists or interleukin 6 receptor blockers like tocilizumab. And this usually happens after the first week when the inflammatory response is more responsible for the worsening disease rather than the virus multiplication per se. So by monitoring interleukin 6 levels and deciding in a person who's deteriorating, you have to understand that sometimes people may have high interleukin 6 levels without clinical deterioration. These people don't benefit from the intervention, but if steroids and probably tocilizumab is started in a person who's deteriorating, they do very well when you suppress the inflammation.
Thank you very much, Ram. And since you have your finger on the unmute button, I'll continue asking you a couple of questions. And they are slightly unrelated, but you mentioned asymptomatic patients. So we're not talking anymore about interleukin 6, but back to our regular antibody test discussion. Now, what is the implication of testing positive for antibodies for asymptomatic patients when we're doing either a sero survey or if an individual is getting the test? So the person in the audience is asking, specifically assuming these individuals are pre-exposed and immunized, possibly or likely from corona viral infections. So for how long do they remain infectious? So what do they do with this result? I think that's what we all want to know.
It is very easy to interpret the results of antibody testing in a person who gives a history of infection, say a history of fever 2 weeks before or 4 weeks before. Then you can understand that if the antibodies are present, the person is no longer infectious. But if that happens in a person who gives no history, who's asymptomatic, and you incidentally detect the test, there is a theoretical possibility that he has developed antibodies maybe within 5-6 days of onset of infection, and he may still be infectious. So in such situations, it is safe to ensure that they are isolated for another 5 to 7 days, so that, as I mentioned, beyond 10 days, they are unlikely to be infectious. So if you wait 5 to 7 days after they are tested positive, isolate them, and beyond that, they are no longer infectious, even if asymptomatic. So that will be the interpretation of that situation.
Thank you. And I've also got one more question. Perhaps it's a little provocative. We are hearing that government is saying that 70% beds across the country for COVID are vacant. But contrary to that, a lot of patients are not getting admissions in hospitals. Ram, you're in the center, you're in the eye of the storm. What is your opinion on that?
See, we know that 80% of people who have COVID don't need hospitalization. They get well. They need to be isolated. In situations where you cannot isolate them at home, we are resorting to facility isolation. But I am sorry to say that a number of private hospitals isolate people and use the hospital beds as facility isolation rather than use them for hospital treatment. And that is why the hospital beds get filled up. This is for various reasons. There are very few hospitals who insist that they will admit only patients who require medical intervention. So this could be the reason for the paradox. And similarly, the government also prefers to take in, because if they are left out in the community, especially people from the lower socioeconomic strata who may be having mild symptoms, they are likely to disseminate the disease. So they need to be put in facility. Maybe hospitals are one good place where they can be put in, and that is a reason.
Thank you. A lot of questions had also been coming up about, immunity passport, etc. I think you have addressed that question very well. Both Ram as well as our other panelists have spoken so much. Nandini also spoke about the nuanced approach that we need for testing. And it's not just a one test and you get this passport and you can travel. So let's be very, very sensitive to that and make sure we have the right test or the right combination of tests. Speaking of combination of tests, Chandra, over to you. I have a few questions that have come up for you about Thyrocare's experience, because you're using different technologies. You've used PCR, you continue to do that, and you've also tried ELISA as well as chemiluminescence. So can you share a little bit about your experience across different testing platforms? What is the distribution and what are the applications, and what sort of outcomes are you able to deliver for your individual patients as well as for your corporate clients? And once you speak about corporate clients, I'll again bring it back to Jyoti to talk about her experience and what confidence building measures we can have through testing. Chandra, you first.
Yeah, as far as testing technologies are concerned, like if you ask me, we are still in the learning stage. But as I said, we are looking at automation platform to scale the testing, because we can't end up doing manual testing like PCR. What the challenge we are facing is like the corporates or individuals who come for such testings, particularly the industries and corporates, they are under tremendous pressure to unlock and initiate their production and service activities. So all they want services yesterday. Like for them, like everyday production losses and runnings in crores. So we have to really like ramp up our testing, and we have to fast enough to give the reports. So we have helped such many industries in the last 1 month with automated antibody immunoassay solutions, because for us, like the other platform have limitation to scale. And also, like one more challenge we come across, in fact, like how labs struggling, similar even the corporate industries, the lack of awareness which test has to be done. So we come across a lot of inquiries from large corporate houses and industries and SMEs. So labs like us have to go beyond testing and guide them on like what test to be performed and what is ideal for the setup. So all this, but if you ask me, like we have somehow like settled with automation platform, because one end we are handling a highly leveraged like PCR kind of workload. As I said, like we are handling 5,000 samples. So other end, like antibody, we want to keep it simple and scalable. So we have kind of settled with automation solution.
Thank you so much, Chandra. Jyoti, you were speaking a little bit about the industry, and although you represent the travel industry, as I mentioned earlier, travel industry is so closely tied to the rest of the economy. You have heard from some of the experts. You have heard from labs. You have heard from clinicians, and you've heard from technology partners about what testing can do. In your view now, what do you feel the industry needs to know or understand, or come hand in hand, walk hand in hand with clinicians and hospitals to better understand this disease and think about safely bringing the workforce back to drive the economy?
Thank you, Shravan. Yes, once again, I'm going to say there is so much of knowledge. I think for me to grasp the entire knowledge that's been said right here has also been too much. So I would wonder how people are confused with this knowledge actually, because there is so much out there and we really don't know. So I think the main thing which I would say again is the right information that we really need. You know, that's something I think the entire medical system should give us the right. There should be a document documented and actually passed on to us. And I'm saying it, maybe it's not related to the question, but I think it's very important for our industry to survive, because we would need this information in the right format, which we could give to the Ministry of Tourism and Aviation and actually filter it down to our members and the travelers, you know, because we are the first face of the traveler when as travel agents, you know. So I think we are very hungry for the correct information, and we are totally confused that what is needed, what is not needed. We all talk, and Indians especially, you know, I think our immunity system is so much better than other countries, and because we are not used to social distancing, we are not used to sanitization, we are not used to hygiene. So I think our immunity system is super. And the day you tell me there is a medicine which I can pop in my mouth and I can go, I think I would just don't care about it and I'll just walk out, you know, because I'm literally, as a traveler, fed up of the lockdown. I've had enough of sitting inside. I have enough of working without a personal help, and all those things come with life. And I think that's what we really need. And as a traveler, that is more important. I really don't care if there's someone sitting with a PPE right next to me. and someone who's taken a medicine and come and sat next to me, as long as I can travel. And that is what we need to actually put it out there in the public right there, that this is what is needed. And this, so yes, tests are going to play a very, very important role again, which I'm going to say that, because but there's something which will come with these tests. Of course, the maximum people right now also, when you're going out in the market and buying something of sanitization, we are looking at brands. So I think brands, trusted brands, which can give you actually the cleanliness and the safety assurance, is something we are actually indulging in. And I'm saying, talking from a very, very common language, not in the medical jargon, which actually is there. And I do understand quite a lot of it now, hearing all of you, and my knowledge perception has gone up. Perception has also gone up. But the point is, I still need that clarity for my travel fraternity and the hospitality and the that we really need brands which we can trust, because that's what the consumer is wanting. He's wanting the safety of products. So factors such as price is also going to be playing a very, very important role, because we have heard from different countries there's going to be $100 test, there's going to be a $150 test, there's going to be a $200 test if you land in a particular country, and you have to pay for it. So all these things are going to be an enhancer, or someone you won't want to travel, because I may have the budget to travel. I may not have 500 more dollars to put on my medical, the moment I land. And the biggest scare which I will be, that I will be quarantined, and the largest scare is that will I get the medical attention there. So I'm very happy taking a test here, taking a health certificate or an immunity passport with me when I am traveling, and say, hey, I'm safe, keep away from me and let me travel and enjoy life. So I think that's a perception which I feel is going to be playing a very, very important role, and confidence and safety, like I said, is going to be there. Yes, like I always say, you cannot fight a fire blindfolded, and we cannot stop the pandemic if you don't know who's infected. So that's where the tests really come in, and I feel that it's going to play a very critical role in giving us that information, to give us how we can start traveling, because society needs that confidence. We need that confidence to travel. We also learn from you all saying, it's a normal viral, it's a mutant, it's going to change phases. We don't know the test we get done today is going to be possible for tomorrow. The medicine we are having today is going to be possible for tomorrow. So all these things, and I would say that yes, like you've asked me, that it is going to be very important to boost our confidence to travel. But one thing surely I would request, and as a lay person, I'm going to request all of you here with such, a huge, wonderful panelists which is here, which are leaders on their own fields, that we would like a good document which we can actually provide to the government, down to actually trickle it down to all and everyone, to say, hey, this is what is going to get you the immunity passport, and this is going to make life easier for you to travel, to open offices, and to move forward in life. Thank you.
Thank you, Jyoti. I see Ram smiling, because this is not the first time he's hearing the term immunity passport. But I have another one or two questions, and I'm conscious of time. So I'm just going to alert my amazing panelists that in a few minutes, I'm going to ask each one of you for one closing statement. So think about that. But in the meantime, I have a couple of questions. Again, technical questions. So perhaps maybe Dr. Nandini or Dr. Ram can take a stab at it first, and then I'll invite Peter. Can you share a little bit about cell-mediated immunity versus humoral? Are you seeing individuals who might have been infected but are not showing antibody positive results? What should we make of those? Or the converse to that is, if you see a PCR positive patient who is eventually antibody negative, what interpretation do we make with those kind of results?
Yeah, so I think I mentioned in my presentation as well that the antibody mediated immunity is not the only thing that plays a role in an immune response. So there was one very interesting study from the Rockefeller University which looked at 150 patients, 150 individuals who had a documented COVID-19 PCR positive infection. About 33% of them did not have detectable neutralizing antibodies. So the keyword here is that they didn't have neutralizing antibodies. All of them had either an asymptomatic or a mild illness. So, and these guys went a step ahead and looked for markers of their cell-mediated immunity, which were very robust. So you can probably just say that these guys did not have neutralizing antibodies, but still their cell-mediated immunity was able to fight off the infection, and they remained only asymptomatic or mildly symptomatic. So that brings us to the question: do you always need neutralizing antibodies to fight off the infection? Probably no. But there's another study that I would like to probably quote here. There was a study which was done on rhesus macaque monkeys who had moderate to severe, I mean, they were initially induced to have viral pneumonias, moderate to severe pneumonias, and a month later, they all did develop antibodies, and then they were given a challenge of infection again. And the second time, they did not develop an infection. So there is a protection that the infection probably offers. Only thing is we don't know for how long, and it is not entirely just the neutralizing antibodies that play a role here. Right. Coming to the second part of the question, asymptomatic persons who were positive initially and then did not develop an antibody, to our experience and a lot of the experts there are a lot of studies also here, even they seroconvert. I mean, asymptomatic individuals also seroconvert at the end of 4 months or 4 weeks or something, but you don't know at which period. Like Dr. Ram has already said, if you incidentally you find someone who is asymptomatic with the serology positive, you don't know whether it was a 1 week old infection or a 5 week old infection. So in those cases, you definitely need to do a PCR and isolate them for a week at least. But seroconversion does happen, but neutralizing antibodies, they may not develop. So that is the distinction here. I think I answered all the parts of the question. Yeah.
Absolutely. Thank you, Nandini. Very useful. I'm going to be turning it over to the panelists now. I've also received many questions about Roche. You know, where do we have the machines, which cities, what is the capacity, etc. I think we can take those conversations offline. Some of you have even asked for additional kits of D-dimer and IL-6. So my team is taking note of this, and we'll get back to you on that. But thank you for your interest. There's another question about using data analytics, artificial intelligence, etc., to study all of these. I think this is another very useful topic. Maybe if Ram could address that in 30 seconds, and then I'll after Ram, I'll invite everybody to just give you a closing statement for half a minute or less, so that we can close the meeting. Ram?
Yeah, I think artificial intelligence and analysis is playing a huge role in this, because whatever information we have, even though the coronavirus has been with us for over 50 years, this kind of mutation first happened with SARS, and the information most we have right now in managing SARS-CoV-2 is what we gleaned of during the time of the SARS-CoV-1. So we have extrapolated a lot of things. We have looked into matters which have happened, or what we have learned from SARS-CoV-1, as we now call it, to come to a conclusion. It could be the immunomodulatory drugs which we can use. Other than tocilizumab, can anything else be used? Which is, we are looking at drugs like baricitinib. We are looking at itozoli. Let me not say that. So several other drugs which we are looking at based on the artificial intelligence. So I think, yes, that's the only way we are going to learn fast and put in trials so that we can, learn to treat this better.
Thank you very much. We have 3 minutes left, and we have 6 people. I'll start from my 12 o'clock and go clockwise. So Chandra, if you can go first with your one sentence that you would like us all to take away from this webinar.
As Jyoti highlighted, there should be a comprehensive guidelines to help large, mid-cap and SMEs. And country has adequate number of immunoanalyzers used only a few hours in a day. Government should encourage its corporate industries, service sectors to adapt new testing strategies and exit lockdown. In fact, they can help with price capping and some kind of financial support specific to COVID safety testing for SMEs. And one more thing I want to highlight, like about we have to think of utilizing antibody data wisely. We can explore the possibility to link with the Organisational app or other passport, which would help to unlock travel and hospitality industry in a big way. That's all.
Thank you so much, Chandra. Thank you for your time today. Peter?
So from my side, I think it's just been a very interesting and very helpful discussion round. Thanks a lot for everybody. I think this shows how truly important it is to work together on a global scale. I think, Jyoti, we're very passionate about going out to the world again and being able to communicate and talk to people and hug people. This is what we all want in the end, and I think this is what we only can achieve together. So I'm actually very happy to be working with a company that actually is supporting this approach. So that would be and also hopefully providing my support here. So
Stronger together. Thank you, Peter. Nandini?
Yeah, so I would also want to stress the importance of population-wide seroprevalence studies, which we definitely require. The only data right now we have for India is that 0.73%, which the ICMR came out with a while ago. That is just not enough. We need to know more information on seroprevalence so that we can start opening up, right? I mean, these blanket lockdowns are, they're counterproductive for the economy and also almost inhuman in certain sects of the population. So we need to have targeted interventions, which can only be the information required for that can only be given by sero surveys, and that is definitely the need of the hour for our country at this moment.
Thank you so much, Nandini. Ram, your closing statement?
Yep, I've got 3 points very briefly. One, I think the only way we can know more is to do more tests. If you do more tests, you will definitely diagnose more people. If you compare US has done 45 million tests, India has still done only 10 million tests, even though we are 4 times more populous. So the first message is for the press and the media, please don't sensationalize. When you have increasing number of cases, every day you find today 5,000, today 7,000. I think this has to change. The more you know, the more you diagnose, the more you understand, the better you can target it. 2 is to do with the stigmatization of people. There is still a lot of problems with people who turn positive. There is still a stigma which I can't understand why, which is something similar to tuberculosis, which we need to get rid of. And on the same lines, mental health is something which is, we are coming across more and more. People recover but have a lot of mental issues. It is said that maturity is defined as your ability to handle uncertainty. And as Jyoti had said, we are in very uncertain times and people are going totally bonkers, not understanding uncertainty. So I think we need a little more clarity, and coming out with guidelines will be a good help. And lastly, the most important take-home message is, please wear masks when you step out of your house. Whether you like it or not, masks are definitely more comfortable than being on a ventilator. So please understand this and ensure you all wear masks. Thank you.
Thank you, Ram. And Jyoti, your words?
Okay, thanks again. And yes, everyone is talking about medical. I'm going to just say one thing, that we need to learn to be positive, and that's very, very important. And let's adopt the new norms which are going to be the life following. So we need to maintain our social distancing, our hygiene, our sanitization. And actually this has come into place, especially in a country like ours as India, when there was nothing existing and people have started accepting this. Let this be here to stay, and let's move forward with that note and say the good doesn't stay forever, the bad will not too, and we will be positive, more of tests, and we will come to know where we stand. Thank you all.
Thank you so much. Thank you so much, panelists, for your time, and the audience, and ET Health for organizing this. Sincerely appreciate these diverse and important views, and hope we all have a safe recovery from this pandemic. Thank you.